Hello, everyone. Thank you so much for joining us today. I'm J.D. Kalmanson, and it has been one of my great privileges and pleasures to start some of the organizations that are being featured today: Montier Behavioral Health, Renewal Health Group, and Conscious Health. And today's topic, which is telehealth, which is particularly relevant and poignant in the sort of accelerated advent of telehealth after COVID-19, is something that we're going to discuss today: its effectiveness, the scope of its efficacy. I'm just going to share a very quick story about Dr. Viktor Frankl, who was once called in the middle of the night by a woman who was frantic, and she was about to commit suicide. And Dr. Frankl calmly proceeded to give her reason after reason to stay alive. And after several hours of this, she tells Dr. Frankl, "You can go back to sleep. I'm not going to go forward with the plan." And sometime later, they actually met, and Dr. Frankl asks her, "Which of the various reasons that I gave you was the one that ultimately persuaded you to not move forward with killing yourself? What was it that I said? I have to know." And she said it was actually none of the reasons. And now Dr. Frankl looks puzzled, and she explains the very fact that somebody who I'd never met, a world-famous psychiatrist, wouldn't go back to sleep until they had convinced me and walked me off the ledge. That's a world worth living in. And so clearly, rapport and trust and the human quality in the therapeutic process, in the healthcare delivery system, is so vital. And that is where the nuanced nature of today's discussion about telehealth is going to be, to hear from the experts exactly how much of that gets embedded and included and doesn't get shortcutted and compromised in the telehealth. So without further ado, it's my privilege to introduce Dr. Timothy Fong, Dr. Anna Yusim, and Dr. Sunder. Thank you for joining.
Thank you, JD. Thank you, everyone, for coming out after lunch. How are we all doing out there? All right. So this is an unusual talk for all of us. Normally we have a bunch of slides, but we're going to talk from the heart, we're going to talk from the head, and we're going to talk from the soul. We're talking about the things that are working for us that aren't working for us related to telehealth. I want to thank Renee for inviting us out, and Monica Montoya for doing all this wonderful stuff. So before I introduce the panel, just to give you a quick tour of where we are. Again, my name is Dr. Timothy Fong. I'm a professor of psychiatry here at UCLA. I run our UCLA Gambling Studies program. I'm on the steering committee of the Center for Cannabis and Cannabinoids. I'm also the director of our sports psychiatry service. But most importantly, I also am an addiction psychiatrist, and I provide services for acute care in our hospital. So one of the first things I always want to make sure, because you come to our campus here at UCLA, you see the beautiful hospital about a quarter mile down there. If you ever need assistance in getting a client or family into our resident neuropsychiatric hospital, that's our hospital, 75 beds, you can just call me straight on my UCLA cell phone. So there's a lot of myths about our hospital, about you can't get in. That's false. We do take Medi-Cal. We have an adolescent unit all the way up. You can even scan my QR code and get you right into my contacts. So the young people taught me how to do that. That's part of that, so that's super, super cool. So I always wanted to start with that. But first off, what we're doing here today, you may say, well, what are you going to talk about? How are we experts? Now, none of the three of us have done papers on telehealth. But like everyone else, over the last 4 years, we've become experts in doing this. How many of you in this room have used telehealth in your practice in the last year? Again, almost everybody. Our number one goal here today is to say, how do we strengthen our ability to use telehealth as a clinical skill? Yes, this is a clinical tool, but just like a stethoscope, just like a sphygmomanometer, it's no good unless you know how to use it and use it well. And that's where we're going to share some of the stories and ideas and strategies that the three of us have learned over a wide variety. So without that, we're going to get right into it and talk about a little bit of things like that. I'm putting the goals and objectives up out here, but as you read through that, first I want to get an introduction of our glorious panel. And we're going to start with Dr. Keerthy Sunder, not from the land down under, but actually is from Temecula, which we would consider to be the South. Dr. Sunder, please introduce yourself to the audience, and we'll go from there.
Thank you very much. Well, good afternoon, everyone. I hope everyone is, gung-ho to get on with it and so forth and contribute towards it. And as the good doctor mentioned, I think, we've all experienced a lot in terms of transitions. And I'm both certified in both psychiatry and addiction medicine. And we had a brick and mortar practice in Riverside, and we had to pivot during COVID and post-COVID and move into a pure telehealth practice. So it was quite a transition. And so we have an integrated Karma Doctors psychiatry practice. We actually have a booth, so please come and visit with us. And in that practice, over a period of time, we actually developed an entire team. And so we'll speak about it a little bit more. And secondarily, we also have an interventional psychiatry practice with TMS in Palm Springs. So we do a lot of personalizing of the TMS and take care of patients. And lastly, as we evolved with our telepsychiatry practice, we developed our own electronic health record called Karma EHR in order to really facilitate this entire process and make it simple so our clinicians don't burn out. So we'll talk a little bit about that. So that's me. Thank you.
That's coming up. And without further ado, our other esteemed panelist is Dr. Anna Yusim, coming to us all the way from New York, where she is a concierge psychiatrist and executive coach, as well as renowned author and expert in spirituality, mindfulness, and integrative psychiatry. How's that sound?
Thank you so much, Dr. Fong. It's a pleasure to be here with all of you today. And I'm the new Chief Medical Officer for Conscious Health. I'm super excited to be joining Conscious Health. It was a really, really beautiful marriage and kismet because at Yale, I'm a clinical assistant professor at Yale, and at Yale I'm starting a mental health and spirituality center. Merging mental health and spirituality has been my passion and interest for many years, and at Conscious Health they have this beautiful, very, very integrative system where they use the top technology and medical interventions in psychiatry, including TMS, including ketamine, including certain neurofeedback practices, psychotherapy, a few other things that we're adding as well, EMBP. And in addition to that, they're going to be integrating a discovery model, which is adding a spiritual and existential framework through which all of the clients and patients that come through our door are going to be able to integrate their own values, beliefs, and have a soul-searching process alongside the medical interventions. So, and as Dr. Fong mentioned, I wear many hats. I wrote a book in 2017 called Fulfilled, How the Science of Spirituality Can Help You Live a Happier, More Meaningful Life. I have a large private practice, both executive coaching as well as psychiatry, and have been using telehealth in all sorts of creative ways since the pandemic. So I'm very excited to be here with you today.
Thank you so much. And again, all of us are about 70% or more now practicing via telehealth. So we start off with a few comments that I have to make sure we leave this room, making sure we understand. Number one, we define telehealth very simply as this: using electronic or digital technology to deliver health care and all aspects of health care. Diagnosis, assessment, screening, prevention, treatment, monitoring, maintenance. And it isn't just simply log on into Zoom, right? It's emails, it's telephone, it's video, it's something called store and forward, where they will send you video themselves and it's there, or in dermatology, sending you images of their skin. That's telehealth. Texting, and soon, of course, AI is all embedded in that, which is why, yes, the pandemic absolutely started the phenomenon of telehealth, but it is here for us to stay. It is now a mandatory part of our training, and unfortunately, we don't do that for med students. We don't do that for residents. We don't tell them, hey, you know, when you look at the screen, you should be looking at the camera, not the screen itself. Hey, you shouldn't be typing and looking over at your second monitor while you're watching the NCAA basketball game. Basic things like that. So we're going to be talking about some of those tips. So a couple key things for all of us to know as standards of care. Because it's telehealth, it's healthcare, that means the same standards of care apply that we would do. I had a resident who a few months ago said, I was texting back and forth with the patient for a few minutes. Does that count as an office visit? I want to bill a 99213 on that. These are examples where that is not standard of care. Number one, if you are engaging in telehealth, you have to use a HIPAA-compliant vendor. The first year of the 2020, 2021 pandemic, you could use FaceTime, you could use Zoom, not for healthcare, you could use Skype. All those waivers are gone. You have to use a HIPAA-compliant vendor. So if you're not doing that, that's problem number one. Number two, all your consent and documentation practices have to be of the same standard of care. Now, for instance, according to some of the best practices that are listed in SAMHSA, as well as Center for Medicaid CMS, they'll say things like, you're supposed to verify. Who does this? Do you do this? At the first intake, are you who you say you are? So in other words, when they log on, do you ask your clients to show them, they show you their idea of who they are? I show them my ID, I show them who I am. So you're supposed to verify that who's on the telehealth is actually who they say they are. That's super important. Those are standard of care practices. The consenting form. One of the other strategies I thought that was really critical is that when you start, you have to say, are you agreeing to doing this visit via telehealth? Would you prefer it by audio? And if the patient says, no, I'd rather have audio, no video, you're supposed to supply and give them that choice. Another huge area that we miss is disability access. How many, do you ever do it in different languages?
We do.
What about folks who are hard of hearing or who have strong, difficult accents sometimes that are hard? So one of the challenges is if you're doing this, you have to say, how do I make sure I have equitable access to my care in other languages for folks who are hearing impaired, for folks who are visually impaired? These are really critical issues of equity. They haven't caught up to all of us yet, but there will be a day. If you deny services to someone because you're like, you know what, I only speak English and I don't have the time to get a translator on the Zoom, that's actually a denial of access to care. So that's a really, really important issue. When it comes to, again, prescribing over telehealth, one of the key things I want everyone to note is this. I'm only licensed in the state of California. So when my clients move to Arizona and they want a buprenorphine prescription, I cannot prescribe it across state lines. But this happens all the time. I say, go find a doctor in Arizona. They're like, Dr. Fong, I can't find anybody. There's nobody here. But I know Dr. Zering is here. And I'll say, well, I can't prescribe it. Oh, please. And then I'll send it across state lines, and the pharmacy fills it. That makes me very uncomfortable because that's not standard of care. Dr. Yusim is licensed in 5 states, but not all of us are able to do that. So super critical information. If you're prescribing across state lines using telehealth, you have to pay attention, and particularly in your California, you can't do it across state. So that's an important area. But a lot more of those tips, but those are some basic tips I wanted us to look at. But we really wanted to explore how we all use telehealth, how we can use it to maintain. And I'll start with Dr. Yusim. One of the big questions is this. How have you been using telehealth to maintain a therapeutic alliance? What are some of the tricks you do? What are some of the tips? What are some of the ideas you have for maintaining that therapeutic alliance for a screen where you may never see the human below the waist?
It's a great question, and I feel that all of our practices have changed substantially since COVID. So I saw everybody in an office. I spent 8 to 10 hours in an office prior to COVID. Now I spend maybe 1 to 2 hours per week in an office. 90% of my practice is telehealth. And incidentally, during COVID, as we were making the transition, and prior to the time that all of us had adjusted to telehealth as a new medium, people would get exhausted and they'd want to meet in person in some way, and it wasn't safe. So you had to come up with creative solutions. So my creative solution was I would meet with my patients outside and we would do walks in Central Park. So that was our, interim, as we were adjusting. And I still continue to do that with patients. I feel like this is what happens. We have a cataclysmic shift in our society that forces us to start doing things in a completely novel way, telehealth being one of those novel ways. And for me, with 90% of my patients being seen by telehealth now, you think about, the deeper question for me is, what creates the most powerful therapeutic alliance? It's known that within all therapy, there's common factors that make therapy effective. And those common factors are, at the very top of the list, therapeutic alliance. But other things include empathy, unconditional positive regard, genuineness and authenticity on part of the therapist, meaning making, joining in the patient with meaning making through insight, goal consensus and collaboration with the patient, having over time corrective emotional experiences, especially when there are a rupture of trust in therapy or some sort of misunderstanding, being able to work through that in effective ways, helping patients to gain mastery, inspiring hope, and providing a more adaptive view of oneself and the world. This is what makes therapy effective. And so when thinking about Dr. Fong's question, what makes telehealth effective, it's really thinking, how do we become masters at helping people to do these things over telehealth? I found ultimately that there hasn't been a huge shift between the capacity to do this with telehealth and also in person. And for me, it really is, I think, meeting the patient where they're at. There are some patients for whom seeing me in person is so important, and they will, say that, and they will insist on that, and then I do everything I can to make that possible. We'll meet in person, which I'm still very happy to do. I'm traveling much more now, so it's not as easy to do that consistently, but we certainly do that. And I also have a lot of patients and clients who actually choose the audio option over the video option consistently for a lot of different reasons. One, they're professionals and get tired of staring at a screen. And so what I say to them in that situation is, okay, well, put me in a headset in your ear, and why don't you go and walk in Central Park while you talk to me? Why don't you actually make our time together a time not only that we're connecting, but a time also that you're doing something good for yourself and moving and actually getting some fresh air. And a lot of my patients love that. And I would say that within the 90% of my practice that is telehealth, at least half of it is audio, and the other half of it is video. So these are a few of my thoughts in response to Dr. Fong's question.
And what platform do you use?
So I use generally Zoom, the HIPAA-compliant version.
Great. And do you have a backup one or another one to use in addition to that?
It's really the phone. The phone is the backup.
What is this phone? How does this work? So, all right, a couple of things, and then we'll turn to Dr. Sunder. Number one, studies have shown outcome rates of telehealth versus in-person, again, for the most part, they're about the same. And if not, we now know, particularly in the addiction world, that telehealth gives us more treatment retention, more treatment engagement, more frequency of visits, things that were not there before. So the data is starting to really show that we can get to more people, which we would fully expect. The other really important law is this. There was about a year ago, whispers among CMS, among other insurance companies, that every single intake, no matter what, had to be IRL, in real life, in person. Well, those whispers have gone away, right? And so now the guidance from CMS, the guidance from almost all commercial insurance is that intakes can still be very much over telehealth. So I think about when I first started this in 2020, like all of us, there's still a significant number of patients whom I've never met in person, whom I've never seen above the waist. And the first couple of years, I found that really unsettling. I'm a Gen X guy, right? I'm used to seeing people and laughing and crying and listening to 80s music with patients. But this is the sort of thing that was unsettling. Now, for this next generation of therapists, this is what they know. They do not know the opposite of seeing only patients and people. So that's some consideration. Dr. Sunder, tell us about some of your very interesting. He set up shop in Palm Springs and Gramercy Park here in LA, which is right by the 105, right by SoFi Stadium. He does TMS, he does ketamine, he does MAT for opioid use disorder. Tell us about what you've learned from your experience with telehealth and particularly how your offices have pivoted toward it. And I'm really curious about how you do the TMS in the telehealth world. So take it away, Dr. Sunder.
Thank you. And thank you, Dr. I'm going to borrow several of the, components that you talked about, particularly walking in Central Park. Might be a bit difficult in the desert, but I thought that was really remarkable that you could potentially do a session and make it therapeutic. I trained with some of the masters in psychotherapy in Pittsburgh, and so we are trying to incorporate all of it. What I'll say is that we do work in an underserved area, so we cover Inland Empire, and so we sort of see a variety of patients from different strata of society, as well as culturally a diverse population. That's one piece. The second piece is that we have an active TMS practice with 3 TMS machines. And the third thing is that we are an academic practice in that I'm on faculty with UC Riverside Department of Psychiatry and on faculty with Arrowhead Hospital. So we have medical students and residents and PA students and NP students who rotate with us. So when we were putting together our practice, we were conscious of the fact that post-COVID, Zoom became the principal way in which you could interact with patients. But we also recognized that there were some limitations with regard to how many folks you could bring on at the same time as you're seeing, for example, if you had students and you wanted to have a therapist come on board and so on and so forth, there were certain limitations in, getting patients to come in. Plus, if you are running a busy practice, you have to have sessions back to back. So there has to be a way in which the Zoom sessions are seamless. So one of the things we did was, of course, build our own electronic health record over a year and a half. And we contracted with a company called Kalera that has designed a HIPAA secure video platform that allows us all of this seamlessness, including, texting and even sharing documents and so forth, and obtaining consent and, multiple functions that can actually be accomplished. So one of the things that we started to resolve was to not be entirely dependent on Zoom, although we still use Zoom. The other part I mentioned to you was that, part of our practice is also addiction. And so to your point about MAT, we clearly have run into various challenges with the MAT part of it, particularly when we are also treating veterans and so forth who require, this across California. So in our psychiatry practice, we elected to not do MAT, but in our addiction medicine with the treatment centers, we are doing MAT. So it's one of the things that we started to look at our challenges, because with telehealth, there are a couple of limitations with MAT, which we observed. I'd love to hear from you since you do so much of addictions work as well as in the audience. One was that, if you really wanted to do the pill count, and if you didn't have a good screenshot and you really didn't have good video coverage, that was tricky. Number 2 was, how do you monitor them on a regular basis with regard to urine toxicology? You could do the oral fluid, but that compliance was becoming difficult. And the third thing was that a lot of them had become isolated. And so for us, it was a challenge to try and get them to be compliant and come on a regular basis. And that meant we had to either extend our prescriptions and so on and so forth, which we were not comfortable with. So we kind of elected to not do MAT in our psychiatry practice. So that's how we have addressed it. I just thought I'd mention a few of these points.
Yeah, no, that's really good. It was interesting. I was at a conference 2 weeks ago, and of course, for years we'd call MAT what? Medication assisted treatment. So then I actually had a client there who said, no, it's medications for addiction treatment. I said, what? That's not how we put it in the literature, but I thought that was actually much better, medication for addiction treatment. So, Dr. Yusim, you do some ketamine, right? And tell us more about how you would integrate telehealth and using ketamine in a private practice setting.
Definitely. This is something actually that is done significantly and frequently at Conscious Health. And the way that we do it is people have an intake via telehealth prior to the administration the day prior or a few days prior. And then they come in for an in-person telehealth session where they are monitored and have their experience, after which they have a telehealth integration. And they're certainly welcome to have more than one integration as much as is needed. And it's very effective and very good. And I think the combination of being able to do telehealth, which offers people the freedom and comfort to do this on their own time, in their own space, from wherever they need, and then have the in-person one-on-one experience at Larchmont, which is the location for Conscious Health, and then to be able to do integration thereafter is a really beautiful synergy. And I think that for a lot of psychedelic integration, so, ketamine is the legal psychedelic, but there is, in my private practice also, a lot of clients and patients who are using psychedelics that aren't always legal. I certainly can't prescribe them, but they're also very powerful modalities for mental health. Not only do they offer a novel biological mechanism for treating some of the most treatment-resistant conditions, but they also, for many, offer a connection to spirit. So a lot of my patients are seeking out those experiences. They may go to Costa Rica and do ayahuasca where it is legal, or they might go to Colorado and or Oregon and do psilocybin where it is legal, or to Amsterdam or Jamaica. And then they will come to me for integration, which we'll do either in person or via telehealth. And so I feel like those are beautiful ways of being able to integrate and to connect with patients in a telehealth setting.
So when you do the integration, will you literally be on screen with the client while they're taking product, ketamine or other things?
No, I would not be there on screen. I would always be there with them after they have the experience. And I actually, myself, I have administered and been present with people, but whenever I do that, I'm always in person. I have not done telehealth actual monitoring. And unfortunately, the case of Matthew Perry is one of, the fatalities and the very dark sides of insufficiently monitored ketamine treatment, which is why we at Conscious Health do the exact opposite. The ketamine experience is 100% monitored, and it's after that the integration happens over telehealth.
Right. Very interesting. And then you pointed one of the reasons we're doing this, when we think about standards of practice, when we think about what could go wrong, suddenly you open up the entire world to have availability potentially to mental health treatment. But then you'll also get certain things like we've seen over the last 3 years, literally online companies offering very rapid assessments, less than a minute, less than 2 minutes, or even just text-only assessments. And then you actually then can purchase psychotropic medication that are delivered in the mail, Schedule I medications, even stimulant medications. We've all seen that. So that's some of the danger when the laws are so relatively loose, because it's going to be very difficult for folks. I get a lot of folks say, oh, aren't you worried that the feds or the DEA are going to come audit you on your telehealth practices? Well, again, that's part of the establishment of recognizing what this is. This is standard of care. This is no different than what we learned from first year in medical school. But there are unique concerns. Like, for instance, I've always wondered, are clients recording me? Am I recording them? Do we need to discuss that during sessions? One time I did accidentally hit the record button, and the client noticed that. And she's like, oh, what are you going to do with that? Oh, I'm so sorry, and I'm going to delete that. And she said, how do I know you're going to delete that? I had another opportunity where the client was recording me, and I did not know that. I only picked it up because I saw the little red dot in the back from another camera. And that led to a discussion of what does this mean, and how do we protect our privacy and confidentiality. So I don't think we talk about that enough when we log on. Some of the challenges I see, for sure, we all deal with. What do you do when the client logs on and they're driving? What do you do when the client logs on and they pull up the vape? What do you do when you log on to a college student who's in their dorm room and their roommates are literally right behind? I had this experience. I'm talking to a patient of mine, and the other roommate says, hi, Dr. Fong. I've heard great things about you. I'm not joking.
No, it's true.
We all have this. So these are all the scenarios that play into my mind. And so I try and follow standards of practice, healthy boundaries, common sense, but I always double check against the two forces: Medical Board of California Telehealth Guidelines, American Psychiatric Association Guidelines, American Academy of Addiction Psychiatry Guidelines. And again, these guidelines aren't updating that fast. Some of the SAMHSA guidelines that are out there are from 2015. Pre-pandemic. They don't even know what Zoom is. So one of the strategies for us here today, if you are doing telehealth, you have to continue to check with your parenting board that licenses you, as well as your main organization, for updates and changes to make sure you're staying accurate. Dr. Sunder, take us through some more about some of your work with telehealth. And I'm curious about, because I imagine you're a very busy physician, 8-10-hour days, very good. How do you stay fresh? How do you keep this skill set? You, like me, trained in an era of paper charts. You trained way before the era of telehealth. How do you keeping this telehealth tool still keeping you motivated and avoiding burnout for yourself?
That's an amazing question. I think, Dr. Fong, I would say that, in fact, it has been really a boon. Wouldn't you agree that we've had telehealth, and most of you would agree that it has allowed you to have a better work-life balance, You're able to schedule things much more flexibly. So that's one piece. And also the other thing is we have a lot of mid-level providers who have come on board. And so that helps also with structuring your practice if you are inclined to have, assistance with other providers helping you with your practice. I think the key, I would argue, and I'm sure you would agree, and you do it, considering the diversity of the work, is to stay sane and stay happy and stay fulfilled and so forth, is to diversify. So that's, as it looks complex, that, we've got teaching going on, we've got, telepsychiatry, we've got TMS, and we've got all of this. But the reality is actually that gives us a little bit of happiness because it is a blend of so many things. I mean, for those of you who love Indian curry, it's like adding all of those spices, but you just don't make a hodgepodge out of it. You just know how much you need to add of each spice to get that beautiful curry out of it. So I think we actually enjoy it. And to your earlier question about TMS and telehealth, I think you mentioned, we actually don't do ketamine because, again, of this whole aspect of monitoring and how do you manage to structure, therapy and therapeutic, oversight and continuation of therapeutic work after a person has had either psychedelics or, something like ketamine. With a TMS practice, we find telehealth to be really remarkable because for TMS, the person has to actually come in, as you know, by definition, they are treatment resistant. So they have problems. And so what has happened now is that we are able to use two tools. Number one is earlier you had to really set in, in-person appointments. They're already coming for that. But in between, if we need to have another appointment to talk them through something, or they decided they wanted to not come for 2 days. We want to check in. We just do a quick telehealth appointment, right? So that's one. So we are able to have a real oversight. Second thing we have introduced, which may be of interest to a lot of you who have, outpatient practices, is we've introduced another tool called PainScript. And this is an app that allows us to do remote therapeutic monitoring. So in between appointments, again, it's another extension of telehealth. We actually have them check in on the app. It's private label to us and so forth. So we kind of get an assessment. We have helped design questions for them to make it entertaining. So every day they get a little reminder, and it's only 30 seconds to a max of 1 minute. Are you compliant with your meds? How are you doing? Do you feel okay? There's a set of questions. And that's a billable encounter, interestingly, and so forth. So there's additional revenue for the practice, but it allows us to stay on top of it.
What was the name of that app again?
PainScript, P-A-I-N and S-C-R-I.
PainScript. Okay. Very, very good. Before I turn to Dr. Yusim for a couple things I like to do to ward that stuff off. Blue light glasses. Does anyone like to wear blue light glasses? So we do have data on that, actually for use of agitation in manic patients inside the psychiatric hospital. So it makes sense for us to use those blue light. I also, never schedule more than 4 hours straight. My maximum attention span is about 30 minutes, but really 4 hours back to back to back. And I also notice on my timing, I don't know if you all do this as well, if it's a 30-minute visit, I'm going to go all the way up to minute about 24. Then I'm going to stop. We're going to close out the visit. We log on. I do about 2 or 3 minutes to do my notes, and then I do about a minute in between appointments to stretch, to do whatever to get a physical movement break, and then right back into the next one. Small, subtle things like that we don't think about. A lot of my friends use stand-up desks, stand up during the thing. But again, the idea of the old days, back to back to back, 10 hours straight with no breaks. Remember, that was a big thing for us when we were residents. You don't take breaks.
Yeah.
And so we had to put that out. That didn't really work for me. Dr. Yusim, telehealth, as we mentioned before, isn't just simply doing it over video. There's a lot of integration of new technologies. So tell us about your experience of incorporating some of those technologies into the telehealth practice, whether it be apps, virtual reality, things that you're using now and things that you foresee coming down available in the next 2 or 3 years.
Gladly. And first, I'll actually respond to also the self-care question, because I just want to say that we as physicians and as therapists are exceptionally good at taking care of others, and often we're not as good at taking care of ourselves. So I love that both of you shared ways in which you do precisely that and how important that is. With respect to the digital apps in the space, so there is right now about 20,000 apps that you can download. And if you look at how many Google searches have been done for mental health issues, 25 billion in the last year. People are needing this. They're looking for it at the level of apps. And it's very interesting. There's so many things happening. With all the apps out there, there's apps for anything and everything that you can imagine, including tracking your mood, including being able to manage your symptoms to some degree, being able to have stress reduction, mindfulness, being able to have even trigger alerts, and being able to attach your wearables to be able to have objective data in addition to your subjective self-report to see how you're doing. These are all the different apps. So there's 20,000 apps, but how are you supposed to evaluate which apps are the ones that are good, et cetera? So there's been many task forces, and they look at 4 primary qualities in evaluating the efficacy of these apps. The first one being that they be evidence-based and have science behind them. So of the 20,000, there's maybe about 20 that have sufficient and good science. And a lot of them were also created by the federal government. For instance, an app for veterans to track their PTSD symptoms, to be able to know over time what the triggers are, and to help them de-escalate and to provide referral sources. So there's 20 really good apps that have the evidence base. Second, confidentiality and privacy, obviously. Third is user-friendliness. And the fourth is interoperability, so the ability to then share whatever you use in your apps with the rest of your treatment team. So the digital healthcare space is really changing the way we practice psychiatry. But the unfortunate thing is it's not very equitable across the board. And there's still about 20 billion people in our country who do not have fast broadband. And there's many communities where that's the case. And it's very interesting with respect to that. Health outcomes are tied more closely to how much you have access to fast broadband than they are to your socioeconomics, where you live, rural or not, and to your education. So when we think about social determinants of health, or all of the social economic factors that affect our access and our ability to get the resources and health we need, this is actually a super determinant, broadband internet. And there are initiatives all over the country, including a federal initiative that $65 billion was just added to, called Internet for All. President Biden and his administration created this in order to have safe, accessible, and workable, essentially, internet all over the country so people can have this access.
One common sense strategy is whenever I do start telehealth, I always say, what is our backup option to communicate and connect should the technology fail? And inevitably, that's actually very important. In the first year, I didn't have one, and then we were scrambling. So the first session, once we establish it, immediately I say, how do I reach you should our internet fail? And that's inevitably, usually it's going to be by phone, but sometimes it's not. Dr. Sunder, a couple things. Do you think there'll ever be a day that TMS will be delivered inside the home, where the device is shipped to your house, and you use it inside the home, and you log in from a telehealth, and you instruct them how to put the band on and hit the button, and I don't know if that's the noise it makes.
I think you already scared everybody with that noise. Hilarious. But so the thing is that, so we have adopted this very early on, right when FDA approved 2008. So it's interesting you bring this up, attending these clinical TMS society meetings and so forth. I think that it is moving in that direction. As you know, in terms of the neurotechnologies that are out there, we are using another technology called NewCalm that basically is FDA approved for stress modulation. And, please visit us and we'll explain some of that. It's really remarkable. TDCS, I think there's increasing research that it will become FDA approved for various, interventions, so people can use it at home. But TMS itself, as you know, it's a class 2 medical device at the moment. So it's a huge dental chair kind of device, and the software itself is, loaded onto another big, box, if you like, and so on. So to visualize that could actually be delivered and that you could train everyone to be able to do that, particularly with the personalizing that we are aiming at, which is you capture the EEG, the brainwave activity, and you can move the coil in different ways at different frequencies. I suspect that it is tricky. I mean, look at neurofeedback. We trained in infra-low neurofeedback, and that is something that potentially you could deliver to folks at their home. But even there, parents with children with autism, they need to undergo a lot of training, and you have to license it under your license. So whilst I think this is something that would be very helpful, I think it would require a lot of effort for all of the researchers and engineers to be able to come up with a device that requires minimal training and that does not require licensed folks to extend their license, and that it has all the safety and efficacy data that you can actually administer it without, as you said, blowing your brain up with the noise.
Thank you. Well, and again, that's the whole point of telehealth, is transmission of care over distance. That's what we're really facing with. Let's turn to the audience. We have another mic, JD. I think we had another mic. If not, I will come down from the audience. We have a few minutes for questions. I'm going to work the crowd a little bit, as we say. Oh, no, please don't clap. We haven't done anything. So let's get some questions, and then we will head off into the breaks. Here you go.
I practice entirely telehealth. I'm an LCSW. I contract with Teladoc and MD Live, and I have a private practice on Zoom. And my question for you, or maybe for everyone, because all of you are psychiatrists, and this might not apply as much, but I'm very concerned about the ethics of the way telehealth is being marketed, specifically BetterHelp, and the way it's marketing to people like it's an on-demand, you can do therapy by text and all of those things that I ethically don't think is really psychotherapy. And I think there are a lot of risk issues related, in addition to exploitation of providers. I know providers that tried to work for BetterHelp, and the amount that they were getting paid was just abysmal. So so both on the provider side and on the consumer side, I have huge issues with some of the way telehealth is just being thrown out there to the general public. So I don't know if any of you have any comments on that. That's what I'm really interested in.
Thank you for that, and our panel will answer that. I'll say very quickly, that's why if you're concerned, you as a healthcare professional need to be an advocate, either write letters or use your professional organization and the power of that professional society to bring this to that attention. Yes, and that with any new technology, you're always going to have people who take advantage of it in ways that are not helpful or potentially hurtful. As we all teach our medical students, psychotherapy has side effects, and to do it poorly can be devastating. So absolutely, we agree. On the flip side, I've also been saying this more and more in conferences where I'll say, because addiction is a 24-hour, 7-day-a-week condition, doesn't it make sense that we need to have 24 hours, 7-day treatment available? So that doesn't mean I need to be awake at 2 a.m. to jump on a Zoom, but it means there are potential ways we can use that to our advantage. So I'm curious about the panel about ethical challenges, any guidance, thoughts about that, particularly as you've seen this evolve in the world and your concerns and ideas that we as a profession can address that? Maybe both of you can address that. Yeah.
Such an important point. Thank you for sharing your concerns about that. And I think, similar to what Dr. Fong said, this is this new area that is burgeoning. And with any kind of new advance, it offers amazing opportunity and many pitfalls. And that's really what you're pointing to. And the opportunities are new ways of practicing, new ways of providing care, whether it's 24/7, whether it's through modalities, texting, et cetera, which to us, we're like, what, texting for therapy? But what if there are people for whom that does seem to work better? And I think the answer to that question is, what's the science? So I think the most important thing is to get the rigorous scientific studies to answer those questions. And with respect to that, so with cognitive behavioral therapy, it's been shown that telehealth CBT is as effective as in person, and it's actually also been shown that email CBT is as effective as telehealth and in person. And for individuals who are reluctant to see a practitioner, self-guided CBT through an app without a practitioner present is equally effective. So it's very interesting, right, that this is what the science is finding. And so with this, I'd be very curious, what is the science for texting, and what's the nature of texting, and how long do they text, and what are the boundaries of the texting? So I'd be very, very curious to see the evidence base behind that. I think your point is so well taken about the ethics, especially exploitation of providers, and that's a supply-demand curve. The ethics and people also making a choice for themselves. Are they going to be working here? And companies, are they able to get away with this? So I think the market will be able to answer those questions for us. But I think that it's a very important point, so thank you.
Again, in a telehealth company that violates standard of care practices, that do things that are against the law, that are against the code of business and professions that we all sign up when we get a licensure, that is a violation and should be reported. I'll just leave it as simple as that. Dr. Sunder, anything else to add on that?
I just wanted to add, I think there was excellent points that as providers, we are advocates as well. So in our practice, we set those boundaries very clearly. For example, we don't use the 99211-212 codes because we believe that by the time a medicated patient sits on the chair, 5 minutes is over. So, what kind of therapeutic alliance can you really have, right? So we set those boundaries and we make sure that we are consenting them, and we don't engage in therapeutic conversations on text and email and so on and so forth. So we stick with it. And this way, then, we as a practice set some of the boundaries and ethical considerations that are critical, so that, other practices then can look up to that, and medical students, residents can learn how to set those standards in the future.
What do you got against 99212? We bill at UCLA usually 99213 or 99214.
Yeah, exactly.
Plus a 90833 psychotherapy overlay. If you can also add in expert codes if you do screening as well for experts things as well. All right, who else out there? No one else? Uh-oh, up here in the front row, the suit. One more. Oh, go ahead and introduce yourself too, please.
Nathan Sutton. I'm also with Karma TMS. One thing that I've seen in the veteran side is an increase of programs using AI, including like AI assisted, like apps that have AI, not counselors, but it's like almost being sold like that. And I'm wondering, with the increase of telecare being available and such, I mean, it's been around since before COVID. VA made a big deal about their telecare program, but really, as AI gets introduced to this, how are we going to protect people and have the client even know that they're talking to a real person? Because AI is getting pretty tricky.
That's going to be next year's conference, right, JD? Well, again, you break it down, AI isn't necessarily telehealth, but have either one of you used AI technology in your professional practice?
Not yet.
I haven't used it specifically. However, I have had many patients who have experimented with it and given me their experiences. And it's very interesting. Like, essentially, patients will go to therapy to bots. to a bot. And on the other side, they'll be telling the bot their problems, and they'll be getting feedback. And it's very interesting. I've had multiple patients tell me it's been a very therapeutic experience. The bot is empathic, sympathetic, saying all the right things in the right way, and they have complete anonymity because they're ultimately talking to a bot. So they have no shame, they can share things maybe they wouldn't even share with their therapist. So it's a very interesting thing happening. That's on one hand. The other thing is there's also, with virtual reality and headsets, people can have group therapy that are, like everybody is an avatar. So you go into this space with multiple avatars into a group therapy space, and people can be all over the world, and there is a visual setting where you're in either a desert or in a therapy conference room. And these things are happening. This is a very real thing. The other thing is these so-called bots, now they have like a bot that is for children, but it also is like a teddy bear responding in the right way to children to help children deregulate and providing other kinds of interventions. So there's more and more coming down the pipeline. I think this is all very exciting and interesting.
So I'll highlight this. I had a resident who generated his progress notes through AI. And they were kind of meh, and he claimed, oh, it saved me time. I said, great. Now what are you doing with that additional time? Are you becoming a better doctor? He was like, eh. So it's new technology. And just like we launched headfirst into telehealth technology, we have to launch headfirst into AI. Paying attention, thinking about it, reading, studying. We cannot run away and say, oh my God, that's so scary. I don't even want to look at it and stick your head in the sand. That would be a mistake. We know that AI is here to stay, and just like with telehealth, there are going to be some companies that are going to take incredible advantage and build things up. There's going to be other folks who do things that you would never dream of in a positive and negative way. So we're not there yet. We're not there yet, and again, but in 3 to 5 years, I can guarantee in a conference like this, there will be a big chunk of sessions on AI. But the core of what we heard today, we'll finish with this thought, is telehealth is supposed to make our jobs and our career better. And I think it is. And we have some tools, and we have some strategies, and we have some practicalities that are allowing us to do the very thing that we want, which is connect with patients, connect with families, and do care better. And I think that's really, really exciting. So I want to thank everyone for your time. Let's give it up for our panel.
Give them a round
and
of
Dr.
applause.
Anna Yusim, Dr. Keerthy Sunder, and for the good folks here at Monterre for putting this together. We appreciate it. Yes, Genesis.
And a round of applause for Dr. Fong, who is the best moderator ever.
Oh, no,
MVP.
no. Easy,
MVP.
easy. Thank you.